our next talk, Dr. D'Souza, University of Oklahoma. She went to college, got her MD, did her diagnostic radiology residency, and got Masters of Public Health. She then went on and did 2 fellowships, one in breast imaging, one in MRI. She currently works for American Radiology Associates. So a little bit about her. Services and activities on a national level, way too many to list, but currently just focus on the ACRA. She's on the committee of chairs. She's on the communication subcommittee for the Radiology Advocacy Committee. She is a board member of the RAN. She is on the patient engagement subcommittee for appropriateness criteria. Concerning her state, local, and practice-related activities, again, way too many to list, but she is the president of the Oklahoma State Radiological Society from 2024 until 2026. She's an ACR counselor. She's the vice president of the Tulsa County Medical Society. And here is a snapshot of her publications and presentations. So here we go, another theme with her, honors and awards, too many to list, but she is a 2-time recipient of the ACRA state scope of practice grant, and that's something that's near and dear to our New York Society. This is stuff that we work on, some of the backbone of our society, so it's great to hear. Here's a list of her current professional memberships. And again, I'm not going to read what AI said about her, but they did a very good job. It does seem like her dual expertise in clinical radiology and advocacy make her a powerful voice for the profession. Her success in Oklahoma provides a roadmap for other state societies facing similar challenges. I could not have come up with that with myself, but I think that is really good. And we are going to hear her talk on advocating for physician-led care. Just having some technical difficulties, please bear with us.
Well, thank you for that very kind introduction. I kind of wish my mom was here to hear that or something. It was very sweet. Thank you.
I can reach out to her after.
So, good morning, and thank you all for having me. How's the volume? Can everyone hear me okay? Yeah? Yeah, okay. Bring it closer. Better? Better? Okay. If it's too loud, tell me no. Okay. So disclosures, sadly, I have none, except that I'm a radiologist, so you'll definitely be seeing some images. So you've already heard a little too much about me, but I was in Oklahoma for a very, very long time. I then went to Wisconsin for some fellowships, and I'm currently in private practice in Oklahoma. But before that, I was in the Oregon and Washington area for about 10 years. I'm actively involved in quite a few societies and been on a bunch of committees, but the ones that are pertinent to this lecture are that I served on the ACR Non-Physician Radiology Provider Task Force. I'm on the ACR Grassroots Committee. I'm a founding member of Take Medicine Back, and I'm a board member and president-elect for the group Physicians for Patient Protection, PPP. This originally started as a physician grassroots effort by social media, but it has grown significantly over the years, and it has evolved into an official nonprofit organization. So this is me gathering you all around the fireplace for story time. You've probably heard the saying that if you're not at the table, then you're probably on the menu. Well, this is a principle I witnessed up close at a very early age. My dad is a physician, so I grew up surrounded by physicians. Most social gatherings included physician friends and colleagues. as a high school kid in the mid-90s, I distinctly remember this one dinner party where everybody was talking about this crazy idea that, they were talking about in the state legislature. Basically, optometrists wanted to perform surgery on the eye, and they were attempting to use the state legislature to expand their own scope of practice. So, and I just remember everyone talking about this like, "Oh, it's never gonna happen. How could anybody allow something like this?" So, I mean, as physicians, we are all well aware of the vast differences in training and education between optometrists and ophthalmologists. This is a marked oversimplification, but ophthalmologists complete medical school, residency, maybe some fellowships, a couple additional, years of that. Maybe they sit for some the pretty intense oral or written board examinations. And optometrists, they don't. So while I'm sure some defense was mustered in response to this legislation, I remember the prevailing sentiment at that dinner being, of course, something like that won't pass. How could anyone think that this is safe? How could you allow someone who has never been to medical school, someone who doesn't have our 10 plus years of training to perform procedures on the eye? Oh, it'll never pass. And no one seemed particularly concerned, just fully expecting common sense and the very legitimate concerns about patient safety and quality of care to prevail. Well, in 1998, the Oklahoma State Legislature passed a law permitting optometrists to perform laser surgery procedures. But that's not all. The bill also granted the Oklahoma Board of Optometry the sole authority to decide what precisely constitutes the practice of optometry. A few years later, in 2004, in response to an opinion issued by the Oklahoma Attorney General, lawmakers then passed legislation which effectively removed traditional oversight bodies, such as the governor, the Attorney General, and the state medical board, and their ability to regulate the practice of optometry. I think we can guess what all happened next, right? With their newly legislated authority and complete lack of oversight, the Oklahoma Board of Optometry passed a rule that further expanded their own scope of practice to now perform surgical procedures on the eye. This was the first time that I personally witnessed a group of people successfully, circumventing this long established, intensely rigorous pathway for, medical school residency of essentially legislating the practice of medicine by non-physicians, despite the objections of multiple regulatory bodies that were put in place to protect patients. Unfortunately, this was the first of many such experiences. Once you start paying attention, once you see what's happening all around you, it's impossible to ignore. On a positive note, this experience it vividly demonstrated to me the importance of physician involvement and engagement in the creation of public policy and the importance of advocacy. I suppose it's what you call a core memory. As a direct result of this experience, I have always taken the time and made the effort to remain actively involved in every state I've lived in during every stage of my career. I've been in practice longer than I want to admit to you guys, but during this time, there have been some pretty significant changes in our profession, but perhaps most importantly, in the overall climate in which we practice. While we had medical and scientific breakthroughs that have advanced our own profession, we've also seen increasing bureaucracy and administration at every level, and a truly shocking rise in the number of mid-level providers. Meanwhile, the number of physicians has stayed relatively stagnant, in large part due to the fact that residency slots have been capped since 1997. But today we're going to talk about the most serious issue facing the house of medicine, all of medicine right now, and that is the replacement of physicians by mid-levels who are not competent to practice medicine, but they're being allowed to do so by legislatures, and they're being forced to do so by their employers. And this has resulted in a degradation in the quality of medicine practiced in the US. This is the biggest threat that we face, both as physicians, but more importantly, as eventual patients ourselves. So these are the bills that PPP tracked and had a hand in back in 2021. And this is in no way a complete list. The number of bills originally filed is much, much more. So for example, last legislative session in Oklahoma, there were about 23 scope of practice bills originally filed. However, not all of them made it to the floor. So towards the end of session, we had 3 kind of big ticket items in play. But every single year, most of these bills return in a different form. And each year, more bills are filed in each and every state. So this was a list tracked by the ACR in 2023. And before we go any further, I just want to stop and say this isn't, a hate presentation directed at any NPs, PAs, or any other non-physician practitioner. I am completely okay with non-physician practitioners being utilized as originally intended, as true extenders that are appropriately supervised on physician-led teams. The problem is that multiple parties are trying to completely alter, if not destroy, this relationship. And, in fact, I do think most NPPs are in their profession due to a real motivation to help patients. These people are victims of a worsening situation in healthcare, just as we are. But that isn't to say that there aren't bad guys in this situation. There are, and I have no problem naming them. First are the corporations, including hospitals and especially private equity, that are just laser focused on increasing profits at the expense of patient care. Second are the nursing academy and the nursing schools that are doing this for power and for profit. And then there are the few NPPs who truly just don't know what they don't know. So how in the world did we get here? I don't want to get too deep in the woods because we can talk about this problem for days, but I'd like to do a quick recap of the origins of 3 NPPs. And when I say NPP, I mean non-physician practitioner. You might have also heard terms like physician extender and advanced practice provider or mid-level. We'll briefly discuss educational differences and the role of politics and profit. So I know this is a really busy slide, but I mostly just want to draw your attention to a couple of similar trends. NPs were first established in 1965. In the 70s, they created an advanced degree, and in the 80s and 90s, they fought for direct reimbursement. Once they secured that, their numbers dramatically increased by about 150%. In the early 2000s, they created another advanced degree, the DNP. And I want to emphasize that this is not a clinical degree. They primarily write papers, study nursing theory, and advocacy. But they've used this to subsequently argue that the title doctor applies to them. And they have lobbied very aggressively for what they call full practice authority, but what I would more appropriately call the unsupervised practice of medicine by non-physicians. And if you look over at the PAs, it looks like they borrowed a page straight out of the NP playbook. So how do you practice medicine without all of our pesky education? How do you skip over a decade of intense medical training, medical school, residency, fellowship, boards? Well, first you secure direct reimbursement, you create an elevated degree, and then you lobby aggressively for the independent unsupervised practice of medicine. There's also an NPP specific to radiology, the RRA. This is a technologist who has completed additional training and can earn a certification in as a radiology assistant through ARRT. The radiology extender concept, it was first introduced in 2000 as a way of addressing increasing imaging volumes, which, interestingly enough, coincide with the rising numbers of NPs and PAs who just might be ordering some of those studies. And a stagnant number of radiologists, because, without any increase in residency spots, there's a fixed number of radiologists added to the pool every year. In 2003, they were recognized as a profession. However, it was with a couple caveats. There was supposed to be no image interpretation, complete ban on image interpretation. They were to be termed radiology assistants, and there would be no independent practice. So what can an RA do? Well, it was originally listed on a single page, but by 2018, it looked more like this. And from what I can tell, some of these changes occurred without radiology input. So we've seen a similar push on scope of practice by RAs. If you remember my last couple slides, this might seem a little similar to you. I would also like to point out in 2020, particularly the nurse practitioner lobby aggressively pushed scope under the guise of the pandemic, even though it made absolutely no sense from a medical logistics standpoint. But as Winston Churchill said, don't never let a crisis go to waste. So let's move on to education. The educational pathway is complex. There are numerous ways to get an NP degree, and schools have worked to make this as easy as possible. There's a standard path, there is also a direct path. You can get an NP after a degree in a BA in fine arts if you want. The Doctor of Nursing Practice, as I mentioned before, it is their terminal degree, but again, it isn't what you think. It is not clinical, it's about writing papers, nursing theory, and advocacy. Many schools have moved to online instruction only. Some may require 2 or 3 days on site at some point in the process. You can get an NP degree online in as little as 12 months. Many places have 100% acceptance rates, and almost all students hold a full-time job during school. I don't know about you, but when I was in medical school, I sure didn't have time for much else, let alone a full-time job. There's no quality control. There's no standard curriculum. There's no organization which guarantees any quality in their education. And as we will see, there's no standard clinical practice. In fact, students generally have to find their own preceptors and create their own clinical adventure, which may simply entail shadowing. This is a post from last year. This is a person who got into a school that just gives you a book and tells you to show up for the tests. This is someone who wants to know if there's anyone to report their own NP program to. Unfortunately, there isn't. There's absolutely no quality control of education, nothing preventing schools from doing as little as possible to get those tuition dollars. So this person goes on to say that their entire class failed every single exam. Instead of doing anything about it, the school just changed the grades. But don't worry, it's nothing important or anything. It's just critical care pharmacology. These folks are both out there looking for, and I quote, the absolute easiest online MSN to DNP program, programs without proctored examinations, all open book and open note. And there were a shocking number of responses to both of these posts, with plenty of programs who met this very interesting criteria. Instead of learning how to diagnose and treat patients, there is a heavy emphasis on nursing theory and training in political advocacy. So here's someone who is very proud of the fact that he went from a BA in psychology to FNP to psych mental health nurse practitioner in 2 years and has absolutely no RN experience. And now he's seeing patients all by his lonesome at a CVS Minute Clinic. But he's not worried. He's following his heart. I mean, he literally says that right at the bottom. I'm following my heart. Don't worry about it. And you see that a lot on their forums. Don't worry about being so woefully underprepared. Just follow your heart. Also popular, fake it till you make it. Your heart's in the right place. This person has decided there's no way you can know everything, so why bother trying? Let's just start NP school, get to those tests with those open book exams, finish as soon as possible, and start making some NP money. Here is someone who is desperate to find a preceptor, saying that they really only need 10 weeks. And honestly, out of those 10 weeks, they really only need 2 days per week. And you know what else? She'll take vital signs or whatever to get this experience. So after 20 days of clinical experience, rich in vital sign taking, she will then be qualified in 29 states to treat patients independently, just as a physician would. So the results of such poor quality education are pretty predictable. This is a report from an NP who does cystoscopy. The NP doesn't know if they were in the bladder or the vagina. At this point, would you believe what they saw even if they were in the bladder? Okay, the top one there, this person has been doing primary care for a year, has already done who knows how many pelvic exams on patients, and isn't sure they know how to find the cervix. Another person is going to start seeing pediatric patients for the very first time and will even be covering a pediatric urgent care. They have no training in pediatrics, but figure it's going to be fine after asking some random people on Facebook for helpful hints on antibiotic prescribing. My father was a pediatrician. There is nothing simple about pediatrics. This is an extremely challenging patient population, and caring for them involves a lot more than just asking for a couple antibiotics. So this is why our pediatrician colleagues undergo a minimum 3-year residency. Here's another example. An NP who's been working for just 4 days and has been assigned by her employer to decide on antibiotics for a cancer patient. She doesn't know anything about it. She took an hour to choose an antibiotic for a patient with lung cancer. And towards the end there, she doesn't seem to understand that pneumonia is a lung infection. Where is she working? At a pretty big name cancer center. This lack of understanding of medicine, it sometimes breeds a certain arrogance. This person truly doesn't know what they don't know. They are running all of these ICUs at night, which I will point out is illegal. She has 0 acute care training, which is required in all states to do this sort of work. She is an FNP, so therefore she had exclusively outpatient care. training. And it's even worse when you realize that a hospital and its credentialing system allowed this. They're promoting it. And some places won't allow a family physician to work in an ICU, but they're allowing a nurse practitioner. This is another example of NPs in the ICU saying, oh, just get rid of that MD. They're not doing anything. Somehow, despite their lack of training, they truly think that they can do it all. And by some stroke of luck, do it better. Just follow your heart. Fake it till you make it. What could possibly go wrong? You might wonder if I just cherry picked a couple bad examples. Unfortunately, no, this is appallingly rampant. So this is something that a friend of mine who is far more organized than I has collected. And this folder particularly made me laugh. He entitled it Unbelievably Dumb. And it's funny until you realize that these are all really basic primary care topics that a third-year medical student could easily manage. Yet these nurse practitioners are out there practicing medicine independently on unsuspecting patients and have absolutely no idea what they're doing, making guesses, asking random people on Facebook, and hoping for the best. You might wonder if the nursing groups and their leaders pushing full practice authority are aware of these deficiencies. They most definitely are. There have even been publications regarding this in their own nursing journals. On the left is an article from 2018 calling out the poor quality of DNP degree programs. On the right is another more recent one from the Journal of Nursing Regulation, which concludes that, and I quote, extensive variability exists across the academic preparation of NPs. NPs should not perform independent, unsupervised care in the ED, regardless of state law or hospital regulations, in order to protect patient safety. So their own journals are saying this. But their answer, the answer of the college of AANP, it's not to actually do anything about the poor education. Instead, they tell people to stop talking about it and stop posting about it. Just be quiet, because it could hurt our ability to keep pushing this full practice authority. This is an actual slide from the main speaker at the AANP annual meeting in 2019. Just again, zip your lips. Don't talk about this. Many nurses and NPs have actually said that they're afraid of speaking out because it could be detrimental to their careers. Rather, this narrative that they keep pushing is that there's 5 decades of research supporting all of their assertions, that they provide a high quality of care equivalent to, if not better, than that of physicians. When you know to listen for it, you'll start to notice that not a single opportunity goes by when this 5 decades of research is not mentioned. Any press conference, article, interview, Facebook post, literally any time that they are lobbying for scope of practice legislation, they just never miss an opportunity to throw that phrase in. And personally, I think it's because of this principle. If you just keep saying something often enough, people start to think, hey, that sounds familiar. Surely it must be true. But when you actually delve a little deeper and investigate these claims, they simply don't hold up. For one thing, in all of the studies that they use to support their right to independent practice, all of the NPs were supervised by physicians and were using physician-created protocols. They involved pretty healthy populations, and they contained small, non-diverse sample sizes. Also, sometimes the endpoints were a bit short and bizarre, honestly. So basically, when it comes to their claims, there are no randomized controlled studies that evaluate care provided by unsupervised NPPs. Studies do, however, show that NPPs can provide a high quality of care when supervised by physicians. NPPs order more lab and imaging tests, something that we're definitely feeling in radiology. They perform more unnecessary biopsies, they have poorer quality referrals to specialists, and they prescribe significantly more medications, including antibiotics, psychotropics, and opioids. So speaking of poor referrals, is there anyone that this NP is not referring to? I'm not sure what the point of this was other than costing the patient time and money, especially when the NP doesn't seem to realize that the referring nephrologist is a kidney specialist. So this is an excellent study from Stanford from October 2022. And it again shows that NPs utilize significantly more resources and achieve worse patient outcomes. How much worse? Well, looking at just the VA and just the ERs in those VAs during the time when they had full authority, we're seeing longer hospital stays, increased preventable hospitalizations, and an annual additional cost of $74 million. This is another excellent site that we should all be aware of. It's out of Hattiesburg, Mississippi, and it was conducted by a large physician group over a 10-year time span. And interestingly enough, the researchers, they actually set out to prove that their model of welcoming NPs and PAs into their system was safe and effective, and that they were essentially equivalent to physicians. This group covered a large area of about 750,000 people, which is basically a quarter of the population of Mississippi, and it included 33,000 Medicare patients. So looking at this large patient population over 10 years, they retrospectively looked at cost, quality, and patient experience. And they once again showed that NPPs cost significantly more and yet achieve worse outcomes. And so those patients who were only seeing NPs and PAs, they incurred an additional cost of $119 per member per month. So that's $10.3 million in potential savings in this one system alone. Cost, quality, and access. Whoops, sorry, I went too far. Oh my goodness. So sorry, guys. Where did that go? Here. Okay. So cost, quality, and access are the three pillars of public health. And so we've seen how the care that NPPs provide is really expensive, and that care is not the same quality as physicians. So despite their constant reported, the repeated claims that to the contrary, that NPPs actually decrease access to physician level care and they increase the cost of care, and the quality of care is demonstrably worse. So with that data and those results, why are we even talking about this, right? Well, that brings us to politics and money. A lot of people are making money, basically billing at 85 to 100% of a physician fee, and then paying as little as possible and pocketing the difference. They also benefit from the over-ordering, the over-prescribing, and over-referral by non-physicians. In the NP schools, well, it costs almost nothing for them to add on additional students. So there's no limit to how many they can add. And every time they do, that's at least 30 to 50K per student. So naturally, there's been a massive increase in the number of schools. There are currently over 400 NP schools. Compare that with 179 medical schools. The Board of Nursing, they can't keep up with it all. Do y'all remember the almost 8,000 fake nursing degrees out of Florida? It was just in 2023, but it's funny how quickly the talk about that died down. I mean, that's 8,000 fake degrees. And we have no idea how many went on to complete online NP degrees. And plus, with a nursing license compact, they could practice in 37 states. Contrary to the AANP claims that they are filling the gap, NPs have not gone to the rural or underserved areas in any significant numbers. The AMA has maps like this for every single state, and those little NP triangles, they're in the big cities, not in rural counties. Many NPs are opening cash-based practices, opening DPCs, Botox clinics, and doing some pretty risky things. And given that there are 183 certifications for nurses, a lot of patients are confused by that alphabet soup that they see after people's names. This is someone doing liposuction without general anesthesia and then posting about it on social media. I assume they just use a ton of local. I mean, maybe they don't realize that there's a real potential for lidocaine toxicity, and they don't seem real bothered about a sterile field either. So bottom line is, patients are being deceived. Many patients don't know that they're not seeing a physician. And there's actually been pushback at attempting to pass truth and transparency legislation in multiple states. I have a lot of material and we could talk about this for a while, but I'm going to direct you to an excellent, very well-researched book that was written by a couple of friends of mine who I've known and worked with closely for a couple years. There was also a follow-up book recently. And throughout the book, they refer to and discuss the truly tragic case of Alexis Ochoa, a healthy 19-year-old basketball player who was treated by an unsupervised, untrained NP in Oklahoma. And if you don't have time to read the book or listen to the Audible version, I'd suggest at least reading the NP deposition in that case, because it's pretty eye-opening. And since I'm giving out book recommendations, I'll throw that one out there too. This is another excellent book, also written by a physician friend. This is an actual ad by the AANP. And I suppose it's trying to reassure us that they're really competent in radiology, but it's a bit of a fail with the upside down film. So we can't really know what's going on everywhere. But using social media, you can get a better idea of the lay of the land. And so, on a post on one of the radiology forums, one radiologist very wisely said that we need to learn from what's happening in other specialties. Anesthesia has been decimated by CRNAs, and I personally know of hospitals that no longer employ anesthesiologists, just CRNAs. Another one talks of how not once but twice NPPs learned their craft or thought they did, and then went behind their back to administration to try to cut out the radiologist. As a specialty, radiology is uniquely vulnerable between AI, NPPs, and greedy hospitals. And our ever decreasing reimbursements, it creates sort of the perfect storm. So personally, I'm just guessing that there will be intense pressure to replace radiologists with AI and NPPs. AI could produce a superficially sounding adequate report, and an NPP could then sign that report without understanding what it means or what it might be missing. They may keep a radiologist or two on to supervise the NPPs, but that's a trap. In the rest of medicine, NPP supervision it usually entails review of maybe 10 charts per quarter, but the physician bears the malpractice risk for all the cases that the NPP sees. I've talked to a lot of ER docs who are dealing with the negative effects of this arrangement. They're not able to do anything, they're not able to do any in-depth interview, but they're forced to simply sign charts. And all of these factors, it might relate to why the ER had a pretty terrible match rate the last couple of years. Other specialties are further down this road than we are. Physicians are being fired and replaced with lesser trained individuals for no other reason than corporate profiteering. This continued trend to put profits over patients and margins over missions. It's pretty bad out there for our colleagues, especially as more and more physicians are in employed positions. In the 1980s, maybe 20 to 30% were employed, but now that's flipped. And for those that aren't fired, the ones that are kept around to supervise the NPPs, it's not about caring for the patient. It's actually about absorbing the malpractice risk for the entire operation and being a shield for the owner or the hospital. Why else would you advertise for an interventional radiologist, but not want them to do any actual procedures? This was an ad out of Dallas saying for $250 an hour, they want you to babysit some NPPs and essentially protect them with your malpractice insurance. Right now, there are legislative attempts to allow NPPs to interpret imaging. There are also physicians who are pushing this, perhaps most notably from UPenn. AB 890 was a heavily contested bill in California a couple years ago for NP independent practice. It was backed by the California Hospital Association, among others. But interestingly enough, the California Board of Nursing, it actually opposed this legislation because they recognized that they simply didn't have the capacity to monitor and regulate all of these licenses, but they were ignored. This bill, as originally written, allowed for NPs to order, perform, and interpret diagnostic procedures. And by that, they meant to include radiographs, mammography, and ultrasound. I mean, it's pretty ballsy, right? I mean, it's quite the power grab, especially when their training is so absurdly lacking compared to ours. We're talking about 20,000 clinical training hours versus 600. And breaking that down even further, that's 12,000 hours of dedicated radiology training versus 0. This bill did pass, though the language was struck because of a lot of hard work from many organizations. So what's happening in the US? It's kind of scary out there. Here's an upper GI performed, interpreted, and final signed by an NP. Shockingly, they missed the abnormality. The kid was taken to the OR and then the PICU. It's fine though. They're experts, just like we are. They probably took this class and immediately went from novice to expert. Just look at all those things you're going to learn. That's quite a list. And all it takes is 2.5 hours. I mean, even Gilligan's Island was longer than that. So certain academic centers have been particularly short-sighted and have even promoted NPPs to the detriment of our profession and even their very own residents. This is a study from UPenn back in 2020, and I think the study is a little generous here. Long story short, they trained technologists for 2 weeks to supposedly read chest x-rays. They then evaluated the difference in speed between them and radiology residents. I believe they were second years. Big surprise, the technologists were faster. The eye cannot see what the mind does not know. but it sure makes for real quick reports. They also downplayed the fact that the technologist had many significant, potentially dangerous errors. There are several other pertinent details that we don't really have time to get to about that study, but we talked about it in greater depth on the Patients at Risk podcast. So I hope I've managed to give you kind of a decently broad overview of the situation that we're facing. I've tried to tackle a couple big points because as radiologists, we learned that perspective is incredibly important. We always want more than one view. We're trained to think big picture, right? We know that we're responsible for everything on that image. And then when we put it all together, the causes and the very predictable effects, just like cigarettes and lung cancer. So you remember my optometrist story? Well, fast forward to another year in another state. In August of 2017, in the state of Washington, HB 1771 sought to create a new health profession, the Doctor of Medical Sciences, essentially allowing unsupervised practice of medicine by physician assistants, recognizing them as, I quote, equivalent to a primary care physician. 4 physicians and I traveled to Olympia, Washington, and we gave strong testimony during the Department of Health Sunrise hearing. As president of my county medical society, I testified and I spoke on behalf of our board, our membership, and my patients. And with the aid of social media and grassroots organizations like PPP, hundreds of letters were written, phone calls were made, and they were directly quoted from by the committee members during the hearing. And a testament to the immense power of advocacy and community organization, for the first time in the history of the state of Washington, a bill was retracted immediately after this hearing, even before the review could be officially completed. That same year in the neighboring state of Oregon, then Governor Kate Brown vetoed a psychologist prescribing bill that crossed her desk, which would have made Oregon the 6th state to allow psychologists to prescribe psychotropic medication. As a direct result of phone calls, emails, letters from organized physicians that were spurred into action, she rejected an entirely inappropriate request to grant prescriptive authority to NPPs. In 2023 and 24, in Wisconsin, NP independent practice bills made it through the House, made it through the Senate. Both times they were stopped at the governor's desk with vetoes and strongly worded language about their reasons for doing so. We had the exact same thing happen in Oklahoma with 2 consecutive years of very hard-won governor vetoes. The NP response at the time basically said, it's our mission to advance the NP profession in our state, to advocate for progress. Personally, I think that's pretty telling. Advocating not for patient safety, not for quality of care, but to advance the profession. These vetoes were achieved via coordinated efforts by multiple physician and patient and advocacy groups from state and national organizations. And I really love this letter that I asked the ACR for. They sent it on behalf of our more than 41,000 members and cited many evidence-based reasons for doing so. Numerous phone calls, emails, letters, in-person visits. I just want you to know that it matters. It really does make a difference. It was entirely due to our advocacy that this bill was vetoed by the Oklahoma Governor Stitt, not once, but twice. So there are those who will tell you that the battle is already lost, or that the horse is out of the barn, and spending any effort trying to stem the tide of non-physicians practicing medicine and sort of putting patients at risk is futile. I strongly disagree with this sentiment. That sense of hopelessness and helplessness, this push for complacency, it's not only out of touch and misinformed, but it's also inherently dangerous for us, for our profession, and most importantly for our patients. I think often the path to negative outcomes is not paved with malice, but with indifference. I mean, all it takes is apathy. People looking the other way and just accepting a supposedly inevitable outcome. Organized medicine can be an incredibly powerful tool to amplify the voice of individual physicians. I've often become aware of potentially dangerous legislation because of my involvement with these organizations and with my relationship with lobbyists. I've then been able to help raise the alarm and mobilize physician efforts. There are multiple physician grassroots efforts which have played a crucial role in the fight to protect patients and promote physician-led care. Physicians for Patient Protection, Take Medicine Back, Association of Independent Medicine, just to name a few. Physicians are patient advocates. We already advocate for our patients in large and small ways on a daily basis. Every time we encourage them to improve their own health or stop smoking or get their mammogram, we're advocating for them and their health. How many physicians are in Congress? How many legislators truly understand what we do on a daily basis, what we struggle with? Unfortunately, this doesn't preclude them from passing laws which deeply impact the practice of medicine. So we need to be involved in making these decisions. Never forget that we are the medical experts. We need to take leadership and we have to do the work. If we don't, it's just not going to happen. So I strongly encourage you to step out of your reading rooms, to pay close attention to what's happening in the environment, and keep one of those expertly trained eyes on the horizon. Get out there and get involved because there's truly only one reason that you would dedicate over, a decade, an extremely difficult decade to honing your craft. It's because you care. So advocacy is simply an extension of this principle. Caring for someone means fighting for them. So while this might seem at times like a daunting task, I think that when we work together and we focus our efforts, we can really accomplish a lot. In recent years, our professional organizations seem to be better acknowledging the situation that we're facing, and they're doing more, making more resources available to us, more funding, specifically geared towards scope of practice. Even the AMA has funds available for state societies to help fight scope creep as part of their 5-point plan for physician recovery. Ted Lasso fans might remember the happiest creature is a goldfish. Why? Because it's got a 10-second memory. So the political environment is constantly changing, and we need to adapt and change with it. Know the big picture, do your homework, and fight for your seat at the table. Keep your message simple and communicate regularly with the people who are supposed to be representing you, because their memories are pretty short too. Lobbying isn't difficult, but it's typically more effective when you take time to know your environment, the players, and the process. Building those relationships, it takes time and it takes effort, but it's what you need to do to affect any real change and to successfully advocate for your patients in your profession. While logic and evidence tend to be our primary influences, this is not always the case for legislators. Cost is definitely a big ticket item because that's typically what they're held most accountable for. And generally, the biggest concern is what do my constituents think? And perhaps most importantly, will it get me reelected? So get in there prepared with your elevator pitch. Oftentimes, you might be talking to them for 5 minutes in a hallway or on the way to a meeting. So make that time count. Get in there with your points, why they matter, why they should care, and what they should do about it. So worried you don't have time to spare? Luckily, leadership and advocacy come in many different flavors. In less than 30 minutes, you could meet a legislator. It takes a few minutes to send an email from your phone. There are apps that make this very easy. Use those to let them know what you think about these bills. You could sign up to be Doctor of the Day at the Capitol. You could apply to be a Rutherford Fellow. I did this back when I was a second-year resident, and it was an excellent experience. The ACR takes 3 or 4 residents per year, and you spend a week in DC with the ACR Government Relations Committee. It takes less than 15 minutes to pay dues and join an organization or post on social media. In 5 minutes, you could donate money. Or even just fill out an evaluation form to call out something wrong in a conference or a lecture. It takes just a few minutes, but if more of us do this more often, it becomes much harder to ignore. So these donations of time, money, and effort, they can have a significant and lasting impact. So they truly do matter. So in the words of Madeleine Albright's, I'm an optimist who worries a lot. And I think we have every reason to worry. Just look at our colleagues in emergency medicine, anesthesia, dermatology, and the ever-expanding NPP scope of practice. It would be the height of hubris to assume that that's not going to happen in radiology unless we take action. Additionally, there's the compounding pressures from administration, private equity, insurance companies, on and on. So there are many external forces that impact our ability to practice medicine, that get in the way, that get between us and our patient. We will all be patients one day. If we don't make the effort to right the ship, who will? Who is going to be left to care for you and your loved ones when you're sick, vulnerable in the hospital? While it might seem like the setbacks are many, and they are, don't let that decrease your resolve. Never stop using your voice to advocate for the good of your patients and your profession. Thank you so much for your time.